Kia ora koutou. Thank you everyone for coming to our first ever campus seminar. So to start us off, we've actually got Barry Milne, our Centre Director. So Barry has a background in psychology and in psychiatric epidemiology. His main research interests tend to focus on lifecourse research, survey research, and the use of administrative data to answer policy-related questions. Today, what he's going to be talking about specifically is the impact of chronic health conditions, not on the individual, but on families and whānau at different life stages. So thank you very much.
Thanks, Steph. Yeah, so this builds in a couple of my interests, actually. Life course research, I'll talk a little bit about that, and whole population data analysis. So this is funded by the 3 Health National Science Challenges, Better Start, of which I'm a part, Healthier Lives, and Aging Well. And they put a group of money, the equal amount of money together to fund life course research. And myself and Offered Hughes and Andrew Spall got together and thought about what we could do along this line. And I want to talk about 2 of those projects mainly, although touch on the other 2. And we have monthly meetings all together. So there's kind of 4 projects overall. I'm going to mainly talk about the one I'm leading, which is a whole population data analysis one, a little bit about the one Offer's leading, and discuss also about the other 2. Okay, so the basic idea here is to extend what we know about the impact of chronic conditions to beyond the individual. Chronic conditions, which is the major focus of the Healthier Lives National Science Challenge, as the kind of middle years science challenge of the 3 that chunk up the life course from early life through to older age. It's got to focus on chronic conditions such as cancer, cardiovascular disease, diabetes, mental health and obesity. It's the leading cause of premature death and disability both in New Zealand and worldwide. In New Zealand, there are high rates among Māori and Pacific, and there's lots of work done that shows the strong impacts to the individual on functioning quality of life. So the Healthier Lives National Science Challenge, for instance, isn't so much looking at what the impact of these things are, because that's kind of well known. They're more focused on interventions and other sorts of things that can be done to improve this. So just take you through some of those points I made on the first slide. This is from Global Burdens of Disease website, and you can go through and you can select individual countries, and this is the New Zealand selection, and it shows the top 10 causes of death for 2009 and 2019. And if you look through, the blue ones are the chronic conditions. So both years, chronic conditions dominate the deaths, and it's only respiratory infections that kind of enters the list, and it's actually rocketing its way up from 10 to 8 from 2009 to 2019. And this research here is from Sylvia Dixon at the Treasury. It was actually the first piece of research done using the integrated data infrastructure, which I'll talk about a bit later, using Ministry of Health data. It was actually a test case for why it would be interesting to put the Ministry of Health data in with the rest of the integrated data infrastructure, which at that stage had tax data and benefit data and lots of Stats New Zealand data. What she did is she said, okay, let's look at people who have chronic conditions and see what the impact is on their earnings and employment subsequent to getting the chronic conditions. So on the top 2 panels there, we've got the impact on the percent who are employed in paid employment 1 year and 4 years after the health system was first aware that they had a chronic condition. It may not be first diagnosis of the chronic condition, but when they're first aware through administrative data sources. And what you can see there is stroke has a big impact on employment that's maintained, others less so, and some of the cancers, for instance, no evidence that there's any impact on employment. If you look at the impact on earnings, 7 to 12 months later, and then up to 4 years later, again you see the big impact of stroke, and interesting there is you see a big impact of breast cancer initially, but that drops away quite a bit within 4 years. Anyway, this is work to show not only the health impacts of chronic conditions, but also the economic impacts. And from the Ministry of Health reports that they put out, well, they used to put out every year, I'm not sure they still do, their Health and Independence report, this is for 2017 data, published in 2018. What we've got there is age standardisation, chronic obstructive pulmonary disease, hospitalisations in New Zealanders by ethnicity and deprivation. You can see two obvious things there. There are big ethnic differences in those blocks there, Māori, Pacific, Asian, non-Māori, non-Pacific, and also a strong socioeconomic gradient there. So social factors impacting a chronic disease. And then from the same report, if we focus in on diabetes, what we've got here, ethnic differences in diabetes as a function of age. And what you can see there is a huge increase among Pacific as they age, to the point where, if you focus on the 65 and above group, around 60% of them have diabetes. So a huge problem in Pacific populations. Okay, so all that is known. What's far less known is about the impacts on the wider family. And people live in families, and so you might expect that having to care for and otherwise live with or have the economic hit from someone suffering from a chronic condition may have an impact. But there's been little bits of work done here, but there's a lot left to be done. The other thing I would say here is, I think in the title that was sent around and in the original name of the application, I say impacts of family and whānau. The reason I'm restricted to family here is just from measurement issues, but that's all we can really focus on. Other people in the same living unit. Not necessarily whānau who may not be in the same living unit. The work that has been done has tended to focus either on carers, and even that has been slightly narrow in its focus, focusing on older spouses who are carers. Children of depressed mothers. There's been lots of work done on the impacts of, when you've got a parent with depression, or parents, or the other way, parents of chronically ill children. So I'll just run through some of those. In terms of carers, as I say, most of these tend to be focused on certain age groups of carers or certain types of carers, such as spouses. This particular report from the Canadian General Social Survey did look at the whole population. And they found that carers report greater loneliness and isolation, they did exercise, and had greater alcohol use. Annual review came out last year focusing on older carers and found, based on a lot of work that this person Schultz has done, as well as summarising research that others have done, and older carers are more likely to experience psychological distress, have adverse health outcomes themselves, have lower relationship quality, so it puts stress on the relationship, and they may have work impacted, although that evidence is less sturdy, they suggest. And another researcher, Kelly Schaffer, has done a lot of work specifically on cancer carers, and in a number of papers that she has written shows that they have worse mental health, physical health, and they have their sleep impaired. In terms of parental depression, and that, to some extent this is my background, looking at family history of depression and influences on the mental health of other people in the family. So I was very familiar with the work that Milne Weissman had done on the fact that having a depression in one generation leads to an increased propensity to depression in subsequent generations. She set up a three-generation, well, set up one to start with, but followed depressed parents to their children and also to their grandchildren. But there's also evidence that children of depressed parents are more likely to be obese, more likely to have behavioural problems, and also more likely to experience maltreatment. About the same, slightly increased risk, but at the same risk throughout childhood, so no greater risk in any particular time. Limited evidence for physical health impacts of having a parent with depression, mostly because very few people have looked specifically. And then going the other way, there's a little bit of work done on parents of ill children, so a systematic review there showing that parents of who have a child who has a chronic condition have greater anxiety, depression, and are more likely to get cardiovascular disease and to die early. And that particular study was one looking at congenital abnormalities in the child. Okay, so summarising this, in terms of the impact on families, we think there's gaps in the literature. Specifically, there hasn't been a great look at the impacts of parents with chronic conditions on the children. So there's been look at the impact of depression specifically, but not the wider range of chronic conditions. There's been little looks, but I think it could be done in greater depth, looking at the impacts on education, say, of children, and on the socioeconomic effects generally on the family. Researchers have targeted in on specific family members, such as spouses. We wanted to look across a range of family members, and also particularly look at different family types, where you've got intergenerational families or 3-generational families living in the same household, what the impact of that might be. Similarly, the full range of carers hasn't necessarily been looked at. There has been less of a focus on young carers, and we've been made aware recently, actually, of people who've done work in this area. And intriguingly enough, I was meeting yesterday with a poverty researcher, Mavis Duncanson, who said that the Children's Commission did some work themselves about 10, 15 years ago on young carers. But she doesn't know what became of that work. Other things that haven't really been looked at are multimorbidity. So we've got someone who has more than one chronic condition and what the impact of that might be. Whether it adds cumulatively to the impact on their families. There's been a little bit of work done by Tony Blakely looking at the costs to the individual based on multimorbidity. And then when you've got, we can, as well as being able to look at individuals with more than one condition, we can look at families that have more than one affected member, and how that might impact other members, other unaffected members of the family. Multi-generational families, as I mentioned. I think just generally, and this is a point I'll get onto when I get onto our research questions. Oh, I suppose I should take a step back and say, you're not going to see any results today. I'm talking about what we plan to do and are just getting underway. Okay, so if you're, if you're expecting to see results, you're not going to see them. Sorry, this is just stuff we're getting underway. But one place I think we can contribute is there's just not a lot known about the number of families that are affected, because it's never expressed in that way. We know the number of people who are impacted by chronic conditions, but not the number of families that are affected. And the other thing to say is, and this hasn't been touched on much, and we can't do it particularly well in our quantitative investigation, but Offa might be able to answer this a little bit in her qualitative investigation, is just the fact that there may actually be positive impacts of being a carer, for instance, or being in a family with a chronic condition. I've presented recently at a whānau where, and she interviewed carers of Pacific people who had a chronic condition, and some consider it an honour to look after their family member, for instance. The nature of the data that we work with means that we can't look at those sorts of things, but I think it's a gap that needs to be filled. Okay, so as well as just having these gaps and filling them, why is this important? Well, one reason is, I think, if you think in terms of burden of disease, and I showed you an early slide looking at the burden of disease in terms of mortality, they don't tend to focus on impacts other than the impact on the individual. And there's a very good reason for this, and that is the data ain't there. So one way I think we can really contribute is to give some sense in which chronic conditions can impact the wider family and quantify that in some way so that someone in the future can go and cost that. So, a couple of months ago, there was a report put out, put together by PwC in association with the Healthy Lives National Science Challenge about the economic and social cost of type 2 diabetes, and projected that into the future. They make a claim, and I flicked through the report and I'm wondering, ooh, this is interesting. I wonder if they took account of family and whānau. And they say there that this can also have a profound impact on the person's family, whānau and friends, but that's it. That's all they said. And then they moved on and then they costed everything else because the data aren't there. So I really think we can make a contribution here by saying, hey, it's not just the individual that's affected here, it's the health and well-being of the wider family and whānau, although we can't necessarily get there, and that's potentially got economic costs. Secondly, and I know there's been a little bit of work done on carers, but I think we hope at least that the work we're going to do is going to give greater recognition and support for the role of carers. We think the extent of caring itself is likely underestimated. We've met up with a woman at Education and Social Work called Lauren Donnan, who's just done her PhD on the experience of young carers. She was a young carer herself and did some qualitative research going out and interviewing 50, I'm going to say odd carers or something like that. And one thing she found was that when she started talking with people, the person that the individual initially thought they were caring for either wasn't the person they tended to be caring for, or their caring was wider than that. So for instance, you may have a situation where a partner is looking after their spouse who has a chronic condition, and as a result, the older children are looking after the younger children in the family. So there's a more caring is needed because otherwise there's other members of the family that might get ignored. So if we're able to contribute to that at all, that would be good. The role of young carers, this woman Lauren Donnan has done a little bit of work on this. Offa herself has done a little bit of work on this, but there's not a lot of hard data out there, and that's something that Lisa at the back is working on. And building on the point before, acceptance that caring may be rewarding as well as or instead of being a burden. And finally, and this is slightly provocative, but I think it's perhaps a next natural step, if burden is underestimated and involves impacts on family members as well as individuals, then should this be factored in when deciding treatments to fund? So the likes of Pharmac, for instance, looks at the morbidity caused by a particular condition and how much of that might be prevented by funding a drug that treats that condition. But the impact of that drug is likely to be wider if it's on a chronic condition or some other condition for that matter, where not only is the individual their health and quality of life improved, but you're improving the health and quality of life of the family around them as well. Now, I think there's a lot of data that would need to be collected before that could ever actually formally be introduced. But you know, if the idea of funding drugs is or funding any treatment for that matter, is to improve the health and well-being of your population, why would you just focus on the individual if that's not the only person affected? Okay. So the basic idea here, as I said, going back, there were 4 objectives of this overall project that we're calling the lifecourse project. And I'm going to talk mostly about objective 1, a little bit about objective 2, and touch a bit later on objectives 3 and 4 about how we're working together a little bit. So the work that we're doing, and I'll go through the team shortly, is to determine the influence of chronic disease on the wider family at different life stages, with a focus on 4 areas: children, households, partners and carers, and older adults. And this is going to be a quantitative investigation using administrative data. That's the integrated data infrastructure, which many people in the room would know about, but I'll explain shortly. And then Offa is doing some in-depth qualitative research to determine the family, household, and community strengths that allow people in the Tokelauan community to thrive despite the challenges of living in families with chronic disease. So we're doing the big overall whole population administrative data research. Offa is focusing on a specific community, and we're feeding data in to help her in terms of the level of chronic disease in that community and other aspects, number of families affected. Again, taking a step back, if there are 60% of Pacifica adults over the age of 65 with a chronic condition, how many families is that affecting? It's got to be close to nearly all of them. And this is going to be an in-depth qualitative study. Okay, so for this research, this is one that I'm leading, and I've got help from various people around different universities. So Lisa Underwood at the back is number crunching at the moment, getting all the data together to be able to do this, and Andrea Teng at University of Otago, Wellington, who's involved with the Healthier Lives National Science Challenge, and has a background in chronic disease. She's a medic as well as a kind of epidemiologist. And then the children and families component is going to be led by Lisa. The partners component, that's led by a team at the University of Queensland. Janine Baxter, who heads the Lifecourse Centre, in the Institute for Social Science Research at the University of Queensland. That should be Martin O'Flaherty, actually, sorry. Janine Martin, Jack Lamb and Yan Shu will, with luck, be over here in January to work in the IDI Data Lab with us to analyse these data. But we're going to be getting some things to them before that. And then on the outers component, Hamish Jameson, that's Lucas Mareka's University of Canterbury, but Hamish Jameson and Ulrich Bergler at the University of Otago, Christchurch. He's an older age researcher who's involved with the Aging Well National Science Challenge, and he's working on the outer component of this research. Okay, so, and this is kind of its genesis in a way. This is how it came about. I sat down and thought, okay, we've got these 3 national science challenges that break up the life course into the early life, that's Better Start, which is those are our focus of Better Start. Healthier Lives, which has this focus on chronic conditions such as obesity, cancer, diabetes, and cardiovascular disease. And then Aging Well, which has those 4 topic areas: healthy bodies, healthy minds, healthy lives, healthy behaviour. How can we do something that approximates life course research when we don't, A, there's not enough money to collect new data, and B, the data that we do have isn't long enough to really go from early life through to later life. And we thought, okay, what we can do at least is start in the middle and look to see whether chronic diseases has impacts at different stages of the life course. In children, for instance, so healthy weight, successful learning and literacy, teen resilience, and on the older age, as well as impacts on the same, if you like, generation or age cohort and spouses, etc. And as I mentioned, what we wanted to do is look at the impact on children, the impact of partners and carers, the impact on families, the impacts of households, and the impacts of multimorbidity and having more than one family member in the household with a chronic condition. Okay, in order to do, well, the reason we can do this is the existence of the integrated data infrastructure, which is shown there. For those who don't know, it's a whole population linking of data across various government agencies and other sources at the individual level. So if you are hospitalised for something, there's a record of that, an administrative record of that, what, the length of stay in hospital, what the hospitalisation was for, that sort of thing, whether anything else developed while you're in hospital. If you go on a benefit, there's a record of that. If you're arrested for a crime, there's a record of that. If you get a degree, there's a record of that after 1997, after 2003 or something, and various other bits and pieces. So there's all these data sets from different sources. Doesn't work on there, does it? But benefit and social services at the top there, education and training, health data, that's all from the Ministry of Health. Those other ones are sometimes from different agencies. Some housing data, some income and work data, some justice data, some people and communities data, including, importantly for us, the censuses in 2013 and 2018. That's under population data. All linked at the individual level. So we know, for instance, from the census, if someone has a chronic condition, we know their family structure, at least as snapshots, 2013, 2018. Very difficult. There was another discussion yesterday around getting ongoing measures of childhood poverty. You need to have measures of household income, and you know who's in a household to do that, and you really only know that at snapshots, at the censuses or from a survey. But we can tell if someone, for instance, has got a chronic condition in 2013, who their family members are based on the census, and then we can look to see what happens to the health and well-being of those family members and compare them to family members in other families where there was no chronic conditions, for instance. Okay, so just going through the sorts of things we can do there. We've got there's a chronic conditions data set, but once we looked into it, we realised that wasn't updated the way we thought it was, but there's code there, at least for us to, or for Lisa to, at least, construct definitions of chronic conditions. Healthy weight in children, that's collected on as much of the population as do a before school check, which is about 90%. And that's between the ages of 4 and 5. All children go through this health screen called the before school check. One of the things they do there is measure height and weight. Successful learning and literacy. All these things we've got some stuff for, but lots and lots of gaps. So in terms of actual learning outcomes, you really have to wait till adolescence before you get any information on, for instance, NCA qualifications and results. Teen resilience, again, it's great what's there, but it's annoying what's not. What we've basically got, and Steph's done a lot of work in this area on treatment for mental health disorders, which isn't mental health disorders themselves, but it's having a mental health disorder and being able to navigate through the system and get treatment for it. And then looking at the impact of chronic conditions on the elderly, for instance. We look at healthy bodies, so hospitalizations, that's the NMDS, emergency department visits, and also outpatient treatments, that's the non-admitted patients collection, national non-admitted patients collection, Chronic conditions themselves. Similar things for healthy minds as we have for teen resilience, but I think also there we might be able to, the advantages of using the whole population is go down to surveys that exist, such as the General Social Survey and the New Zealand Health Survey, where we can't look at the whole population there, but we've got enough really, because we start with the whole population to look at slightly more detailed information about mental health. In terms of the healthy living, there's sort of wellbeing indicators that you get from the General Social Survey, Household Labour Force Survey and the Census, and healthy behaviours really only from the New Zealand Health Survey. But point is, because we've got the whole population integrated data infrastructure and it's got a lot of different components to it, and we're able to define chronic conditions, we can look at impacts across a wide range of areas. So I alluded to this before, but basically the idea is we define and characterise households as at the 2013 census, a snapshot, and we define chronic conditions among household members. There's little bits of deviations amongst this. For instance, one of the researchers wants to look at new onset chronic conditions. And these are the chronic conditions we're focusing on. We've chosen 10. The first 8 are ones that you'll find in the Ministry of Health Chronic Conditions dataset: acute myocardial infarction, cancer, COPD, coronary heart disease, diabetes, gout, stroke, traumatic brain injury. Another couple we added in there, mental health, because we think it's likely to have a huge impact, and it would be remiss of us to not look at that. It hasn't been a focus of Healthier Lives, but we decided we wanted to look at it in any case. We had to stop somewhere, so we haven't looked at substance abuse, and we're not looking at asthma. And because of the interest of Hamish Jameson and other older age researchers, we're looking at dementia as well. And Steph and I have also done a little bit of research in this area, or doing a bit of research in this area. So, I'll run through the research questions that we want to answer with this. And they're more or less split, half descriptive questions and half analytical questions. And as I say, I think descriptive questions are quite interesting because I'm not sure anyone has done this before. So how many families include a family member with a chronic condition? How many family members include a family member with multi-comorbid chronic conditions? So that's where someone's got more than one chronic condition. And how many families include more than one family member with a chronic condition? And all of those questions can be looked at by family type, for instance. As well as looking at by, well, we've got the family structure there, as looking at whether this differs by socioeconomic status, ethnicity, family structure, and other things we could potentially look at, but certainly those three. And then the substantive questions is kind of one each for each area of the life course that we want to look at. How are health, education, and wellbeing outcomes for children impacted by living in a family with a chronic condition? How are employment, income, and physical and mental health impacted over time for the partners and carers of chronic condition sufferers? How is the health, mental health, and lives of the parents and elders of chronic condition sufferers impacted over time? And how does having a family with a chronic condition change families and households over time in terms of family composition and household resources? So that's where it's handy having 2 snapshots of the 2013 census and, as badly as it was done, the 2018 census. So this is how we plan to do it anyway. Things may change slightly. But this is, sorry, I'll go on to the next slide. We run analyses on the whole population and stratified by major ethnic groups: European, Māori, Pacific and Asian. as well as subject group analyses run for the Tokelauan ethnic group to feed into the work that OFFA's going to do in Objective 2. Also, when I first was writing this, we were wondering how much we should focus on the differential impacts of different chronic conditions. And in discussion, we thought we wouldn't do that very much. We'd mostly focus on chronic conditions generally. But the more we thought about it, the more we thought that's silly. And thinking back to that Sylvia Dixon research I showed earlier on, there are clearly different impacts by different chronic conditions on the individual. So you might expect that for the family as well. So I think we will be looking at differential impact for different chronic conditions. Account for the functional impairment of conditions. We had a meeting with Andrea Ting a couple of weeks ago, and she's going to go away and look at the extent to which we can define either functional impairment or severity of condition, because the hypothesis there being that a more severe condition is likely to have a greater impact on the family than early stage diabetes or something like that that's under control. As well as, as much as we can, try and identify protective factors. So, for instance, it may be the case that impact is mitigated if there's enough family members around in the household who are disease-free. And it may be that if you're not forced to move house because of socioeconomic reasons or otherwise, things are a bit better for you. But if it's the case that the impact of the chronic conditions impacts resources to the point where you have to actually shift out of a bigger home into a smaller home, or have more people move into the home, maybe that has a greater impact. So we can look at these sorts of things. So just an example of how we might do an analysis. Does growing up in a family with a chronic disease suffer impact on educational attainment? Just as an aside on this one, at the whānau I went to and presented this in a shorter form a couple of weeks ago. Just a discussion in the group actually of 100 people, and there were people saying that they know of people who are young people looking after others with a chronic condition, and they've left school early to do so before they've been able to attain a qualification such as NCEA. So here we aim to, at least this may change a bit, we identify families in 2013 with chronic disease sufferers with children aged 12 to 16. Why 12 to 16? Because if you focus on 12 to 16, most of those will have achieved NCEA 2 results by 2019. So if we start in 2013, the latest data we have available is a couple of years old, up to 2019. Maybe we'll have some up to 2020 by later this year. But the focus at the moment is defining people 2013, following them for a period of time, and we think we can follow them until 2019. Match, although there might be other ways to do this, as I've been discussing with Steph for another project, match children by age, sex, ethnicity, deprivation, region to a group of children without a chronic condition in the family. Matching is the conceptually simplest, isn't necessarily any better than other ways, but once you do that, you can compare the groups to determine whether NCEA 2 attainment is more or less likely among children and families with a chronic disease sufferer. And then if there is an association, we can investigate the impact of chronic disease type, as I mentioned earlier, and potential protective factors among children in chronic disease families using an interaction type approach. So if you have lots of other disease-free family members around you, are things better than if you don't have that? So we've got two different trends, those without lots of disease-free family members around them and those who do have that. Okay. Right, I'll move on to shortly talking about OFFA's project, but just to finish up here and talk a little bit about the other two projects. Limitations here are well, there's probably lots of limitations that I haven't even covered off, but limitations that come to mind before we undertake this work are the sort of limitations that you have generally working with administrative data. Administrative data is good for understanding what is going on for populations, but if we find an effect, for instance, looking at the last slide, children less likely to stay in educational training, we don't really know why it's come about. We just see that children who are in this group end up having these outcomes and children not in that group have different outcomes. We have no idea why because there's no data collected on that. And we may see an effect in aggregate, but that may mask lots of different things going on for individuals. So lots of children, for instance, who are looking after a chronic disease sufferer may not have their education impacted, but at the population level, more do than the other group. And as I mentioned before, we can mostly only focus on negative outcomes. We can't uncover all the positive impacts of caring for a family member. Okay, so I'll just mention briefly now the other two projects before moving on to talk briefly about Offer's project, just in terms of how we're working with them and how we plan to work with them in the future. Okay, so all this is to say it's extremely important that we augment our findings with in-depth qualitative analyses that Offer's going to be doing. So two associated projects, this is project 3 and 4 for the Life Course project, Te Kura Mai a Tawhiti. That's led by Mihi Ratama and Will Edwards in Taranaki. And they have got an early childcare, a whānau-based early childcare program. And what they want to do as part of this project, and they've got other research projects attached to this, is develop a conceptual framework and methodology for a life course wellbeing approach based on that early childhood centre or centres they have down in the Taranaki. And then E Kore o ne e Ngaro, led by Tahu Kukatai at the University of Waikato. And what she's working on is developing genealogies or whakapapa for the Ngāti Tipa hapu and iwi. And she's got that work underway already. And what she wants this research to fund is to document how they're doing it, essentially. Document the conceptual framework for a whakapapa-centred approach to intergenerational wellbeing research. And based on the genealogies she's developing there, by going out interviewing people from this hapu. Okay, how we might work together, because they seem quite disparate projects, and to some extent they are, but we all sit in and meet once a month about this. I think there's possible implementation pathways there if we think about, if we find particular factors that are important. Implementation pathways maybe through as well as the Tokelauan community that Offer's going to work on, but also the communities in the Taranaki and Ngāti Tipa that Tahu's working on in the Waikato. Also, we've had meetings to discuss issues surrounding Māori data sovereignty and how we might work best there. And this was mainly with Will and Mihi, actually. And the advice there was we're best, in the initial stages at least, to focus on the resources we've got in team, so them and Andrew Spall and others, to guidance on use of data. They also suggested that given the study is nationwide, not focused specifically on a particular community, and it's using Stats New Zealand data, it should be governed by the Mana Auditi agreement between Stats New Zealand and the Data Iwi Leaders Group, which was something that was signed a couple of months ago, basically saying they'll share information with each other and they'll keep each other abreast and treat each other's data with respect and a couple of other bits and pieces, and agree to meet twice a year. Okay, moving on just in the last component here to talk briefly about Offer's component here, which Offer can talk about in great more detail than I can, so I'll just sort of give a high-level overview of what she's got planned. The Tokelau population, which is a relatively small population, but it has high health needs. I showed before the overall diabetes level in the Pacific ethnic groups generally, and Tokelau is number one amongst those, but they're seldom the focus of research because it's a relatively small population. There was, however, one study done a long time ago by Ian Pryor, the Tokelau migrant study, migrants from Tokelau to New Zealand. It's called one of the most prominent examples of population context epidemiology during the modern epidemiology era. And some of the people who Offer is talking with now, members of the Tokelauan community who are involved in the study, involved in helping out with the study at least, were involved in that original study that Ian Pryor did. So the study that Offer is going to be doing will allow historic comparisons. The population is a relatively small one. It's more or less in two areas, Auckland, South Auckland and Pororua. It's well networked and less geographically spread than other New Zealand Pacifica groups. The name of the project is Intergenerational, Integrative and Intellectual Pacific Properties and Pathways for Life, IP for Life. And as I said before, what Offa wants to do is determine the family, household and community strengths that allow people in the Tokelauan community to thrive despite having a member of their family with a chronic condition. Their qualitative investigation in 2 sites in Wellington, again mostly around Pororua, where 53% of the Tokelauan population of New Zealand live, and Auckland, 24%, nearly a quarter of the Tokelauan population live. And doing some purposive sampling through collaborating service providers, that's Pacific Health Plus in Pororua and the Tongan Health Society here in Auckland. And the plan is to engage community leaders, that's already happened or happening, and family members as co-researchers to identify solutions to addressing the impact of chronic diseases within families. The plan is to have 12 community workshops, 6 focus groups and 15 family interviews. That'll be facilitated by Pacifica researchers that can speak Tokelauan. But the structure of those are going to be determined by everyone in the group, essentially. So it's not going to be walked in, you're not going to walk in with an idea of exactly how it's going to go. It's going to be determined by the group that you're talking to at the time. Using a Talanoa model, which is based on storytelling, with areas of love, warmth, humour and respect as part of that storytelling. And then once the data is collected, some narrative and thematic analyses. And this is led by Offa. There are the 2 service provider leaders that she's working with, John Fiso and Glenn Doherty from the Tongan Health Society. And she's engaged Tokelauan leaders in Auckland and Wellington, and will be employing Pacifica research interviewers. So these are some of the groups that she's engaged. The Auckland group and the Wellington group, I can't remember exactly which one is which. Well, there's a double up in both groups. Offa there in the top photograph. Okay, so mostly focusing on the research that I'm leading in the whole population analysis, but touching a bit on Offa's research. What do we hope to achieve here? Well, what we want to do is to, using both studies, using results and implications of both studies, contribute to policy development around support needed for families who have a person in the family with a chronic condition. I think that's an important one as well, as I've mentioned, better capture the wider impact of chronic conditions for each chronic condition. And this can contribute to cost estimates and maybe down the track, treatment funding decisions. But I think more broadly, and not specifically focused on this particular research, most of the research that is done does focus on the family, but this is one example. It's not the only one, but it's one example where we are explicitly looking at family members and the impact on them and not the impact on the individuals themselves. And in so doing, I hope this raises awareness that what happens in families, what happens in individuals does affect families, and just focusing on individual impacts misses a lot. And I hope that there's as a result, there's a move away from individual focus, which there still needs to be, but just a realization that there's impacts on families as well. Okay, that's pretty much what I had to cover. So if you've got, just pass it on for questions now. Thank you.